Nicolas Girard, I'm the head of medical oncology at Institut Curie in Paris. So HER2 mutant non-small cell lung cancer is a small subset of patients with non-small cell lung cancer, 2 to 4%. We have this Bayer 2927-088 or Bayer 88, which is an oral tyrosine kinase inhibitor that is inhibiting HER2. And the SOHO-01 trial is a global multi-cohort trial that assess this compound in patients with EGFR or HER2 mutated non-small cell lung cancer. So after those expansions, dosing of 20 milligrams twice daily was chosen for expansion. And at ELCC 2025, I presented the results of 2 cohorts. The first one being cohorts of patients who were HER2 targeted treatment naive, but who had previously received systemic therapy. And second one, patients who had received prior treatment with HER2 directed antibody drug conjugate. So 44% and 44 patients and 34 patients. What we see from the SOHO-01 trial is a high response rate in HER2 targeted treatment naive patients, 72%, which is quite high. We have a duration of efficacy that is quite long, 9 months in this cohort of patients. So it means that after treatment with chemotherapy plus minus immunotherapy, the Bayer 88 has a high efficacy. The second cohort was that of heavily pretreated patients, more than three or more lines in more than half of the patients. And we see a response rate of 35%. This is control rate of 53%. So quite high in the setting of no more options after treatment with chemo, IO, and antibody drug conjugate. The safety of Bayer 88, it's mostly diarrhea, grade 1, 2, no discontinuation due to diarrhea. We probably need to implement proactive management for diarrhea, which is the most frequent side effect with this drug. And we have this ongoing phase 3 trial, the SOHO-02, in the first line setting versus chemo plus immunotherapy for patients with EGFR mutated non-small cell lung cancer. The COCOON trial is a trial which had the objective to assess whether prophylactic dermatologic management could prevent grade 2 or higher side effects, dermatological side effects, that are associated with the administration of amivantamab plus lazertinib in patients with EGFR mutated non-small cell lung cancer. So EGFR mutated non-small cell lung cancer, historic standard of care is osimertinib, and there are other third generation TKIs that are available in China and Asia. Amivantamab plus lazertinib demonstrate an overall survival benefit versus osimertinib. That is a significant benefit and more than 1 year difference in median overall survival. So it's a new standard of care for the first line treatment of those patients, but this combination has been associated with higher risks of dermatologic adverse events, especially in the first 4 months. So COCOON assessed whether this prophylactic dermatologic management versus standard of care could improve this situation. COCOON is doxycycline, clindamycin lotion, chlorhexidine on the nails, and ceramide boys moisturizer on the body and face. And at the first interim analysis, very early time point, 4 months median follow-up, we see a benefit with the COCOON regimen from 77% of the patients presenting with grade 2 or higher dermatologic adverse events after a 12-week follow-up to 40% of the patients. So it's a twofold decrease in the incidence of dermatologic adverse events. We have a twofold decrease in grade 3 events, twofold decrease in dose modification of amivantamab or lazertinib. So clearly, it goes with Mariposa. It goes with amivantamab plus lazertinib. COCOON has to be implemented part of this treatment together with VTE prophylaxis and prophylaxis for infusion-related reactions. Well, a lot is coming in thymic epithelial tumors. We had this historical chemotherapy, cytotoxic chemotherapy regimens for the first-line treatment of patients with advanced metastatic thymic tumors. We have seen new trials combining chemotherapy, carboplatin plus paclitaxel with anti-angiogenic agents, including ramucirumab, bevacizumab. So this may be one option for those patients. We have also seen data with combination of chemotherapy plus anti-angiogenic agents, the MARBLE trial with carboplatin plus paclitaxel plus atezolizumab, reporting on quite prolonged progression-free survival, which is probably the best endpoint in those patients. So moving from chemo alone to combination of chemotherapy plus anti-angiogenic agents plus immunotherapy. Second line setting, we have chemo, we have anti-angiogenic agents, sunitinib for thymoma, lenvatinib for thymic carcinoma, immune checkpoint inhibitors as single agent or combined with anti-angiogenic agents. So again, the combination and sequence, it's moving. What is good is that we have more options for the management of those patients.